Evet hocam en sonunda. Okay, so Dr. Tony James, he's been here with us for the last 3 days and delivered some excellent speeches, and he's an honorary senior lecturer at Oxford University and lead clinician at Highfield Adolescent Psychiatric Inpatient Unit in Oxford, United Kingdom. So today he will be talking about the psychopharmacological intervention for early onset psychosis. It's all yours in hand, Dr. James. Thank you.
Okay. Thank you very much indeed. Well, thank you very much indeed for the committee for inviting me to speak here again. Very grateful. Yeah, this talk, if it leaves you confused, that's fine, because this is a confusing field, and I'm glad to say that actually many more opportunities and ways of viewing psychosis have opened up since the old type of looking at schizophrenia and virtually nothing else. So if it leaves you confused with more questions, then it's probably done its job, which isn't the way you normally expect to come out of a lecture. But hopefully, that's the whole point, is young people being engaged and asking questions and thinking about and discovering new research opportunities. There's a lot to go through, so if you have to leave beforehand, I perfectly understand, but I'll carry on. So what I'd like to start off with is some of the neuropathology, because this interested me first of all when I started, was, in post-mortem brains, people with schizophrenia, there's no gliosis. And if it's suggesting that the changes in the brain are neurodevelopmental, and in fact, probably before the second trimester. So how come you get neurodegeneration with an onset of an illness that's not until teenage? That's a very interesting question. And also doesn't involve cell death, but instead a loss of dendritic spines and synapses. So it's interesting. So it's not a loss of neurons, it's a loss of their connectivity. So that's an interesting thing, just from neuropathology. And here's a slide from Guide, Rappaport et al., which you will have seen a long time ago, but it bears review. And this is the normal brain here. And you look at the top of the slide here, actually, as you go down, blue means less. So there's a progressive loss of grey matter in a normal grey matter maturation. And that's quite interesting because, and the way you look at it is, if in young children, they, before the age of 2, there's increasing synaptic connectivity, so that I connect to you, connect to you, connect to you, and so on. So it's an extraordinarily complex telephone exchange. But actually in adolescence, what you want to do is make this connection and that connection more important, and with respect, cutting out that connection, so that actually I can prioritize certain information highways, and that's why you get loss of grey matter. So that's normal, and that's why you have to always do control trials, because this is those with childhood onset schizophrenia. Forget that slide. This is here, significance of grey matter loss. Pink being the highest, and you can see progressive from back to front loss of grey matter in childhood onset schizophrenia versus controls who are losing grey matter in any case. So you can see this is a complicated picture. And actually what you see here is, I've just talked about, in the young children is increasing synapses and onset of adolescence pruning. And some people say it's the loss of these pathways, certain pathways, meaning less important or aberrant pathways are actually opened up, and then you get the psychosis. And this is actually indicating where the cells lie in layer 3 here. So it's not throughout the brain, it's particularly stratified. And here is the normal, I've written a reference here and you have the papers, so it's be worth other slides. But actually you can see here, this is a regression line here showing increase in synapses, cells here, dendrites, loss later on. And okay. And this is actually what it looks like. Again, the picture here, and this is the cells here, and this is how things pan out. They actually look in life down the microscope. Okay, now this is actually quite an important slide. I've left the references here for you to look at, and I would recommend reading them. But this is really exciting. So that actually you have prenatal. We know it's a highly genetic disorder. Apart from autism, probably one of the most highly genetic disorders we have in psychiatry. So they have genetic factors, perinatal complications, certainly that is true. And we think there's probably unaltered synaptogenesis at this particular point. In childhood, we now understand that childhood trauma is a particularly salient point for psychosis. Maltreatment, sexual abuse, physical abuse, and so on. So that relatively new thinking, urban living, and that's a complicated ethnic minority status. And very interesting study done in Institute of Psychiatry, showing that those living in inner city areas, yes, they had an increased risk of psychosis, but if they moved to the more affluent areas outside South London, to say Bromley and so on, the persons living there were not necessarily of the same ethnic minority, and they felt alienated and increasing paranoid. So actually moving to a more affluent area where you're not at home with other people increases the risk of psychosis. And now here we're having as already said to you, autosynaptic pruning. Then you get here the risk of substance abuse and so on. And we'll talk about this absolutely. I'm going to show you a slide later on, which I claim is probably the most important slide you're going to see this few days, and dopamine dysfunction. But look at this. Actually, the onset of schizophrenia we're talking about now, not psychosis, but schizophrenia. You have increasing negative symptoms and some positive symptoms until positive symptoms mark the first episode of psychosis, which if you're treating young people in school, and you're a school teacher, you're going to find this young boy here or young girl gradually dropping out, losing interest, and at that point having a drop in IQ. Not when they have this point here, it's this point here that they actually have the drop in IQ. And that's the interesting thing, because you won't pick it up. My colleague, Tanya White from Netherlands, might be able to actually help us in the future look back retrospectively at those who actually are not doing terribly well at school and have these negative symptoms. But they won't be shown up in general classroom, because actually what do? Just sink into the background. They don't do very much. They're not causing a problem, except when he turns out and says, I am Jesus Christ, or I am Allah, and I want to, and I'm going to come here to save the world. And he or she's admitted to hospital. And you get this rather sad course here. So I recommend, what I also recommend for trainees is that you need, in your training, you haven't got time to read all the papers, it's impossible. What you need to do is target those people who make sense. And this person here, Oliver House, makes a lot of sense. If you just take something away today, follow him. Don't follow me, because I'm not researching schizophrenia at the moment, so that would be a real waste of time. So, what about the development? Neurodevelopmental hypothesis. Not all cases of schizophrenia or psychosis are neurodevelopmental, but some are. And look at this really exciting pathway here, increasing myelination, which goes on for many a year. But here, prefrontal excitatory synapses decrease, and inhibitory synapses actually increase. And this is across the age range. So this is the real crucial point here for the onset of, we're talking about schizophrenia, we're not talking about hypopsychosis, and I'll come back to that. And here, just another slide showing the same thing here, but actually probably a little bit more detailed in terms of actually what dopaminergic projections here, glutaminergic here, and interneurons GABA. And you can get here the onset of particular, here environmental factors seem to be having an effect here. We understand that. Postnatal brain, if possible. here we're thinking about, could we actually stop progression at this particular point? I think that's a wish that we have nowhere near got near to yet. And as I would take point with Tonya White's talk yesterday, it's going to be public health interventions, not drugs and all that. That's just for the birds. So what do we know? Pregnancy and maternal stress, maternal infections, deficiencies, nutritional deficiencies, and intrauterine growth retardation, and birth complications, not minor, but severe. Socioeconomic factors, childhood adversity, including maltreatment, and I really press that because if we've been speaking 10, 15 years ago, perhaps we shouldn't have emphasized that so much, but we do now. Immigration, both first and second generation, birth late in winter, raised in cities, older fathers and younger parents, and of course, ubiquitous use of cannabis in adolescents, and I'll come to that in a minute, particularly those with high tetrahydrocannabinol content. And in fact, I speak, when I'm dealing with young people who are using cannabis quite heavily, I say, please smoke the cheaper, older stuff. If you smoke cannabidiol, you're likely to chill out, as they say. I'm not recommending it's against the law in the UK, but the chances you developing schizophrenia are much, much, much less. But if you start before 13 or 13, you're in trouble. And we'll see a slide of that, yeah. And these. Now, autoimmune disease, I've got a slide at the end talking about that, particularly if you're assessing young people, you must do the autoantibodies. The trouble is, if you just do the static ones, not the live ones, you're almost certainly going to get a negative result. So you need to consult someone who actually has expertise in this area here to get the live live antibody tests. And this is another slide just to kind of emphasize all this here. So we've got racial minority status here, stress, it all seems to boil through stress here, and cortical dysregulation, genetic factors, and this is how it happens here. And we're going to spend some time looking at this particular, because many people have said this pathology of schizophrenia, at least, not necessarily psychosis, but it maybe is in the synapse, and we've got to look at that in a little bit more detail. And this is just gives you the odds ratio here. So cannabis use is not smart, but if you're in town and you're in town and you're smoking cannabis and you've had childhood trauma, then it's possible those things will interact. Now, sorry. So this is actually interesting work from Judith Rappaport's group and Gide and Gogte. It's interesting about the actual loss of grey matter, and I'll take you through these slides here. So here, age 12, progressive loss, but actually you can see here quite considerable in those with childhood onset schizophrenia. By no means typical. Sorry. But actually, these are the siblings of those children who have childhood onset schizophrenia. And this becomes the interesting point, because they also have loss of grey matter, but everything stops at the age of 14. If I just go back, you can see it does not. There's 14, 17, and so on, things like this. So although they have a similar genetic profile, not identical, whatever happens for the siblings, loss of grey matter compared to normal controls seems to stop at the age of 14, which is, I think, interesting. Now, the person who won the first award here actually went to do a PhD with Marek Kubicki, and we've done some work here. I think my name's somewhere along there, or Tim Cronan, that's myself, yeah. And it was suggesting, let's have a look at the white matter tracks in those with schizophrenia versus controls. And you can see from this that actually this is the way you move forward, young researchers. You can't do it on your own. What we did do is small, underpowered studies, relatively, but actually what through Enigma and groups run by Kubicki is combined data sets. And it's not just combining the data, it's combining the raw data to do the analysis on. So this is what we did here. And it's suggesting, well, look, if white matter trajectories are different in schizophrenia, and we know they are, How do they differ? That's a really interesting kind of thing. Is it just shifted down? Is there a peak across that? So there's a peak developments earlier or later? Or is it just a faster decline? And does that vary by brain regions? And look, that's the whole brain. Interesting. And I apologize, well, no, don't apologize. You can have a look at the paper if you want. These actually project onto here the different tracks here. So look, that looks like a decline. That looks like a decline. That looks like a shifted trajectory here, and so on. Things. So it's quite complicated, as you would expect. And in fact, when you look at the individual pathways here, the blocks, the circles here indicate different from normal controls. And actually, when we come back in the next slide, do they have different trajectories? That's interesting, because that's all together. So some are actually stable. That's interesting. Actually have a faster decline. And this here's a deficit and decline. So the white matter tracks, yes, they have altered FA, which means probably altered connectivity, but the pattern does seem to differ across the ages, quite differentially. It's a large. Now, as I said, Oliver Howe I would recommend here. So what he's saying, genetic factors, and we know the heritability of schizophrenia is about 0.7, 0.8, so massive. Impaired glutamatergic regulation, increased striatal dopamine release, and that's the interesting thing. One thing is this is psychopharmacology. All our drugs, D2 blockers, block post-synaptically. What we want is drugs that actually stop the increased striatal production in the first place. And no drugs do that yet. But that's an interesting thought. And here, you've got abnormal salience, aberrant salience. I think Robin Murray and Cruz all spoke about this. It's like everything in this room being alert to you straight away, and you can't focus it. And actually, in the acute psychotic stage, it's quite interesting, because I remember as a junior doctor, it was at the Bethlehem, we admitted this young boy who had only been in the unit for about 2 hours, and we had a large group, totally bonkers idea really, of about 40 people, staff members and patients. And this patient sat down. He had not spoken to any of the patients or staff apart from a few. And he sat down, slightly disinhibited in a highly alert state. This is what I'm talking about here, the salience. And he said about the OT on one side, he said, she fancies you. And everyone looked around and thought, that's possibly true. They'd had kind of eyeball counseling, everyone kind of, but there had been no intimation here that they were actually formed a couple as such. And both were highly embarrassed. But he picked that up in a non-verbal language. And it was obviously slightly disinhibited to be able to say this. But actually, it shows you how alert he was to those social cues. We'd all knew that, but actually had buried it. So that's what you do. Psychotic symptoms, acute psychosocial stress, and you've got a dangerous, a non-ending cycle here if you don't watch out. Now, this is what I think is the most important slide you've got in the conference this week. Prove me wrong if you want, but I don't care. This is normal, and this is those with schizophrenia. Again, you review there. So we take it through. Blue is dopamine, yellow is glutamate, and pink is GABA. So what we've got here is D2 acting on a glutamatergic drug, neuron here, release inhibited, and this is excitatory, okay? Over here, you've got, this is the cortex, midbrain and striatum. The cortex here impinging upon a GABAergic drug here, again, that's inhibitory. So you get reduced striatal dopamine normally. That's for you and I, hopefully. However, in schizophrenia, there's loss of control. So the inhibitory D2 is reduced, so the excitatory neurons are actually increased. The GABAergic drugs here, because of hypofunction of the NMDA receptors, means there's increasing inhibition here and increasing striatal dopamine here. Now, that may or may not make sense to you if you've not seen it before, so in which case I recommend the paper. But it's showing that whatever drugs we need or whatever treatments we need to use is going to have a complex action on the cortex, midbrain, and striatum. And actually what you get here is increasing release of dopamine. And the drugs that we often use act here, which is not what you primarily would want. And here's in really a massively complicated slide showing how the postsynaptic fit in a little bit more detail. I won't go through that, but just to say that here's the interneurons here, pyramidal neurons here. We can have an inflammatory response via microglial or astrocytes here, and oxidative stress on the myelin sheath here. And our understanding of exactly what microglia do and astrocytes do is changing. For instance, we've done some work on stem cell. We've tried to do some stem cell work, actually replicating the idea that microglia actually, well, just bite them. They just digest dendritic spines on here. We can actually see that now in vivo. Not in vivo, in vitro. Right, another important slide here showing that the answer's not dopamine. It is dopamine plus glutamate. And here you see over the response to treatment here with glutamate in particular. Really, if we look at most of the tracks here under treatment, this is obviously using spectroscopy imaging. There's really not much difference between those who remit and those who do not remit, except in the thalamus here. So those who actually remit seem to show lower levels of glutamate, but those who do not actually have higher grades of glutamate. And what do we do as psychiatrists? When we have a patient who does not respond to our dopamine blocking drugs, we give them more and more and more. When actually we can see it's wrong physiology. It's not working because it's the wrong metabolite you're attacking. And this just shows that much the same. And this is just a schematic diagram showing how these drugs, how this actually, the pathway here with GABAergic and pyramidal cells interact to give you abnormal EEGs, abnormal connectivity here in the brain. And the interesting thing was talking to colleagues yesterday, and I worked with a colleague in Freiburg in Germany, suggesting that the EEG abnormality in schizophrenia is usually abnormal. But what you get is epileptologists or neurologists who just said, it's not epileptogenic, therefore it's normal. No, that's not true. It's non-epileptogenic, but still abnormal, and that's the point. But we've lost out on this here. And this is the important thing here. This is those with healthy, plateauing out of their IQ as time goes on. Those with schizophrenia, they have decline often before the first onset of their psychosis. Maybe I will have a dialogue hopefully with Tanya later on to see whether any of those have had IQ drops off and whether they would be in that risk group here. But those with bipolar disorder perhaps have a sequential drop during each psychotic episode if they do have psychosis. Right, time for a change. Should we play? This is Jim Van Os from Maastricht.
Actually, the main selection criterion for a TEDx talk is that you have to be slightly crazy.
Can you hear that?
And I distinctly remember that I wanted to say something important about it, but I'm getting a little bit confused because you, sir, I saw you touching your glasses just now, whilst at the same time the lady over there was distinctly scratching her nose. I saw you. And there is something going on between the two of you, some sort of communication. And I distinctly get the impression that you want to ruin my TED Talk. Is that true? So maybe some of you start to worry a little bit about my mental health. And maybe after my TED Talk, you want to take me to the local hospital for a psychiatric assessment. Now let's imagine I tell the psychiatrist that apart from these delusional thoughts, I am also hearing voices, and that I haven't been functioning very well for the last 6 months. By telling this, I will meet likely criteria for one of these so-called schizo diagnoses. Let's say I meet criteria for diagnosis, and since
So, another researcher in schizophrenia that I'd recommend, apart from Robin Murray, who works in London, colleague Jim Van Os from Maastricht, who actually really has researched the psychosocial aspect of schizophrenia and others, and actually talks about the fact that we spend all our time talking about schizophrenia when actually the majority of psychosis is not schizophrenia. And this is an example of a person who has abnormal beliefs at that particular point in time, but may not fulfill criteria for schizophrenia, but nevertheless has psychosis. And this is what we can look at. Psychotic experiences here, psychotic symptoms as such, and those with psychotic disorder. So the reason for that, I recommend his TED Talk. It's great fun, and it's illustrative. And if you're a teacher of young people, students, medical students, things like that, I recommend getting that view, because they come in and say, oh, I know about schizophrenia. Well, that's the whole point he's making. That's not enough. Schizophrenia is very important, but it's not the whole of the psychotic continuum. And in fact, here we're talking about environmental exposures here, which you would talk about stress, immigration, cannabis use, and so on, things like this. And it depends upon the kind. This is normal, so you can have a psychotic type experience here, but actually with more stress, more and more stress, and so on, things like this, developing into a frank psychotic disorder. Now, this is actually quite an interesting study, really, European study here. So this is, don't need to worry about the two different colors here. The one's the corrected odds ratio. Maybe I shouldn't say that. If there's any statistician in a room here, I apologize. But here this is just cannabis use. He's never used it, okay? And here is daily use of cannabis more than 10% of the time, so actually. But actually what I want to point out here, it does seem that if you use tetrahydrocannabinol or less, you have a reduced risk of psychosis. Maybe I shouldn't mention that. Again, you might think I'm just surprised that I suggested that. But it does look like the more you use from an early age, the increasing risk you've got of psychosis. So it's not smart. Now, this is another slide which I think is terribly important from Dan Freeman, who is professor of psychology at the University of Oxford. Terribly nice guy. But what he said, and when I was taught schizophrenia, I thought, there we are. That's the group who have psychosis here. This is a normal population. The twain should never meet, because these are really crazy people. But actually what he's shown is in terms of paranoia, hey-ho, presto, there's a continuous exponential graph there. It's continuous. It's not discontinuous. There are not a separate group. What I wondered, I haven't spoken to Dan Freeman, but I'm just wondering, in the time of COVID, do you think that just slips up there? So that actually it's still the same, but all of us are slightly more suspicious. Be interesting to look at. Well, it's too late now, but it's an interesting thought. And what he did was look at paranoia and actually divide it out into a kind of physical threat, conspiracy, people against me, so on, so on, so on, or social harm. And actually looking at this, there is a complex interrelationship between paranoia. And we looked at this and I think, well, I'm pretty sure I'm on this paper as well, although I didn't do an awful lot of work. There's paranoia here, and the strongest relationship, as you may or may not be surprised, is peer relationships. And that can be protective or otherwise. So relationships really count, which is suggesting a possible way of treatment. So Dan Freeman, again, I'd recommend him. He's worth following if you want to. There's no sound on this. Can you hold it there for a sec? So what you're doing here, you're watching this, but actually what you're doing is having a VR, so virtual reality. You have the headsets on with the glasses, and you're looking at this here. And you can alter the slide as you go along, so that actually you saw that man pick up his hand and go like that. You're thinking, what's he going to do? And he just strokes his head, and things like this. And people become closer on the tube. This is pre-COVID, I've got to tell you. But the idea is that you induce a paranoid situation or threatening situation in there, and the person can actually overcome that in that. So it's actually a psychological treatment, and it works like a dream. You can imagine the other corollary, which is straightforward, those who are fearful of heights or social interactions. You can manufacture all those in virtual reality, and after a few sessions, the person actually reduces their inhibitions to heights or threats in others. So this is a good active treatment for paranoia, which is one of the major components of psychosis. So, next. This is one of our young patients. If you want to listen to her, I think this is fascinating.
First, when I started hearing voices, they said things like,
"They're out to get you. What are you doing? You're always getting it wrong.
Be careful what you're saying
You can't
here.
trust anyone."
For God's sake. Yeah, just like that. I tended to believe them, and it made me feel suspicious and paranoid.
Yeah, you should be suspicious. Don't tell anyone anything. I'm looking out for you. I'm the only one you can trust.
I really wasn't able to distance myself from them.
You don't need to be distant.
When they were talking all the time,
They're not interested in you.
I-
You know you're not interesting. Why are you telling them
I
all
found
this?
it really hard to
You can't
concentrate
trust them. You don't need to.
tried to send them
Can't
away.
count on us. We're not going anywhere.
or ignore them.
Great, so now you're
Or argue
ignoring
back.
us. You know you're not.
Shut up! I don't need to listen to you anymore.
You do need to listen.
I
You
found it really
will
draining
listen.
and
They
exhausting.
want to get rid of me. They want you to get rid of me. Listen to us. Why are you telling them
And when
all
I
this?
couldn't get rid of them, it was totally
You can't trust
demoralizing.
them. Watch your back. Why are you telling them all this? You can't trust them. Watch your back.
I worried that I would never get better. In therapy, I learned, rather than fighting with the voices,
You don't need to fight
to
against
find a way
them.
to make peace and distance myself from them. For example, giving them names to take some of the sting out of it. Or
These
thinking
aren't
of them
very
as
nice,
annoying friends
particularly good
constantly
names.
giving advice that I don't need to listen to. I learned to think of them as background noise, like the radio on in the kitchen. This makes me feel a little more in control, and my voices don't affect me so much. I'm able to get out and do the things I used to do before this started, like meet up with my friends or dancing.
Okay, thank you. I hope that was interesting. And
At first,
at one point, while she was talking and the other voices were talking over it, became very difficult to concentrate and hear. I mean, English may be your second language, but believe you me, even if it's your first language, you would have found it difficult to follow her track, because that was to exemplify. It's difficult to follow your thoughts, really. And it works. And guess what? Antipsychotic drugs do not always work on reducing auditory hallucinations. But the combination of two might well be in order. I rather like that, actually, to be honest. She didn't have paranoia. So we recently had a look at, well, what is the prevalence of childhood onset schizophrenia? Is it worth actually wasting health service money in Turkey or the UK? Well, perhaps not. These are females in red, blue here. This is hospital admissions over a 15-year period here of all hospital admissions in the UK. So that actually I've shown as I showed because Michael Goldacre just he likes statistics less than I do, but I like statistics. That is an exponential graph. So if I knew that age here, I could predict all the rest. It's completely that way. But here's the thing. If you look at hospital admissions recently, we've introduced a community service following our colleagues in Australia. Actually, it was first discovered, the early intervention psychosis, in Buckinghamshire. But the person who did it was such a sour psychiatrist, no one listened to him, so he went to Australia instead, and they adopted it. But what we did is early intervention psychosis, so everything's in the community, medications in the community, meeting the persons in the community, they meet with the school, offer jobs and things like that. And they're putting me out of a job. Well, I've got other things to do. If you look there, there's a huge decline in male admissions for psychosis. So this is one government quango that actually works. So if you have to have that, you probably have it in Turkey, early intervention psychosis services, but I don't know that really that's been shown quite so elegantly as working for this age range. Oh, hang on, but for childhood onset, well, there's just nothing. It's virtually reduced. But it's not like pediatric bipolar disorder. This is really low. But nevertheless there. Now, Marianos Kyriakopoulos, I hope to pronounce the name right, very kindly allow me to use some of his slides from the South London and Maudsley. I said I'd reference them, thank you. And the drugs we use are complex, and they're not uniform in any way. If we look at aripiprazole, that's a dopamine D2 partial antagonist. And look at this here, clozapine, really a dirty drug. Olanzapine, and so on, things like this. Some have sedative properties here, but it's a complex array. And so you probably think these drugs would work well, perhaps in combination. And I'll put that forward to you as a consideration. But the important thing, and this is well known now, is that we're looking here now at what optimal level of drugs you use. When I first started psychiatry, we just gave more and more and more. But all you developed was adverse effects. This is the therapeutic window here, and suboptimal here. You want to get into that area here, 60 to 80% of D2 blockade. Beyond that, you're wasting your time. And I think most psychiatrists would accept that now. But look at the difference in terms of effects here. And here this one reduces nightmares, H1 is high hypnotic. So you can choose your antipsychotic in terms of the side effect profile. In fact, early intervention psychosis services do actually offer them to this kind of profile to the patients and say, what would you prefer? So, do they work? Yes, there's overwhelming evidence D2 blockade in psychosis works. So and that's an older study, a slightly older study now, but nevertheless works against positive and negative symptoms. But let's just have a look. There's a network meta-analysis here. And what comes out of it? Well, actually, despite the differing chemical profile of these drugs, they all seem to work quite well, except we come here that clozapine is probably better than the rest of it. And this is more recent meta-analysis here. My colleague, Professor Phil Cowan, says he doesn't understand meta-analysis and things like that, though he publishes them, of course. It's a bit like saying, my team, Plymouth Argyle, played Manchester United, beat them once. Manchester United beat so-and-so and so-and-so. So Plymouth Argyle actually could beat Barcelona. Well, they probably could at the moment, but it's not very likely. But there we are. What do we get from this? pairwise meta-analysis, that's not the network, and pairwise, all those drugs reduce positive symptoms. Clozapine was significantly more efficacious. In pairwise comparison, only risperidone, lurasidone, and arsenipine showed significant reduction in negative symptoms. With a network meta-analysis, the best was clozapine. And that's not news to you. It's just there for reference, I think. And this is a study by Celso Arango in terms of looking at lurasidone. Yes, comparison, that's lurasidone there, suggesting olanzapine might be slightly better. This is just another measure of improvement here, so more much of a muchness. But lurasidone actually has less side effects. Does that make sense? But the important thing is, I've only prescribed lurasidone on one occasion, and it actually made the patient very sick. But maybe I'm just a bit cautious now. So, things you have to do, you have to measure weight, height, waist and hip circumference. I think that's terribly important, and all those things you should be doing, because unfortunately, as we say, the metabolic side effects are massive, especially worse in younger people. So you've got a duty to make sure that you do monitor this. This is follow-up the normal population here. Those on they had controlled medication, that's right, in this study, I remember that right. So they are on medication, but not antipsychotic. And here you see the risk of diabetes type 2 increases with the length of years follow-up. Quite substantial, and it does depend upon the dose of chlorpromazine equivalents you're actually offering. And this is the heat map of the drugs. So if you want to give a drug, we now are warned in the UK with the NICE guidelines not to use olanzapine as first-line treatment. You're not meant to do that. So I use amisulpride. It only has one index there, but amisulpride has been shown in the optimized trial, European cross-nation trial. I don't know whether Turkey took part in that, to be as effective for adults as any of the others, if not more so. So you need to be aware, and exercise, diet, well, this is for the morally righteous people. Exercise and diet, it just doesn't work. So as soon as we start a patient with a long-term psychotic disorder, I start them on metformin. Because the weight gain, I mean, it's impossible to stop. And if you cannot do that. So I do that. Now, I had a look at this slide here, because it's terribly important that you do know about the PR interval, but the important things for these drugs is QT interval. And I was looking at this morning. I've been measuring QT interval incorrectly, although I've got a further degree in medicine here. I thought it was to that point there, but it's not. You're going to take a slide going down here, and it's where it crosses the isoelectric line here. So it's that QT interval, not there, it's there. Most of the machines now measure this for you, but if you don't, you need to be able to know how to do this and do this correctly, because anything over 440 is a bit of a worry. The last patient I sent to the John Radcliffe Hospital had 490, 495, and even the physicians were getting a bit worried at that level, because you can get toursoide de points, and that's lethal. So I'd just recommend the paper, if you want. And we're just going through the acute dystonia. It's extremely worrying, but I do not prescribe routinely anticholinergic drugs. Why? They're lethal in overdose, so that's just dim to do that. And akathisia, you need to be aware of this, because it can look like a worsening psychotic or agitation, things like that, and the more drugs you give, the worse the situation gets. And Parkinsonian and tardive dyskinesia, fortunately, much rarer with these drugs. And actually, interesting enough, that probably clozapine is a treatment for tardive dyskinesia, so that's a one-up. And actually, it hasn't been indicated, I didn't put the slide in here, and I'm sorry, I should have done. Whole population surveys showed two things from Finland and from Denmark, two things I want to take away. One is the mortality rate for those taking clozapine was lower than any other antipsychotic medication. And it may be because they have enhanced surveillance. Because in all the countries, Turkey included, you cannot have clozapine unless you have regular blood testing, things like that. So that's actually quite important when you're telling patients and families that actually in the longer term, the risk is reduced. And the risk may be also reduced because of the reduced risk of suicide with the clozapine. The other thing, which I didn't mention, sorry, I should have had the slide, there's an awful lot of slides here anyway, is that probably combination antipsychotics may well be the best for some. In the UK, we're told one psychotic change, some things, but it may be that the two might be helpful, and if you look at the chemical profile there, you could understand why that might be appropriate. I can't say to you, you must do that, but they are. So, in the early intervention psychosis thing, if there's two antipsychotic medications failed on adequate doses, reasonable trial, review diagnosis, review adherence, they may not be taking the medication, and whether there needs to be psychosocial interventions, which I suggest there should be, consider clozapine. Well, again, Marianos Kyriakopoulos Sphere have done a review, and actually it works. Clozapine works in this age range as well as it does. And in fact, Judith Rappaport and I think it's Gogte looked at the outcome after 30 years of treatment of childhood onset schizophrenia with clozapine and suggested it's better than the effects in adolescence or adulthood. So don't be put off by the idea of not using clozapine in the very young. You make a mistake by not using it, but unfortunately, the side effect profile is quite concerning. But then you are physicians, that's what you're paid for. That's what you should be able to do. And I'm afraid to say some psychiatrists shy away from that, but that's what you're paid for. That's why you went through medical school to train. Our colleagues in general medicine give drugs that are far, far more toxic than this, but you do need to be aware of it and manage it. I'm not suggesting. This is the one that's always worrying me. The tachycardia I get, and not in 35%, it's 100% of cases. But I refer it to a pediatric cardiologist and they just say so. So sometimes I give a beta blocker. And the interesting thing, negative symptoms portend a poorer outcome. And that might be the core of schizophrenia rather than positive symptoms. It's an interesting thought. There are psychological treatments here again, CBT, CRT, cognitive remedial therapy. We did a study, just a pilot study, comparing 3 arms, CBT and CBT plus medication, or just medication in those with first onset psychosis, to see whether there'd be any difference between the group. And the evidence was that pretty much all are effective. Now, this was a preliminary trial. We haven't done a definitive trial. Whether that be funded, I don't know. But the idea of treating acute psychosis without medication, if you refer to this as a MAP study, is perfectly legitimate. You do not have to go to medication immediately. You may choose to, but you don't have to. And the outcome, this is a relatively new paper, is complicated. So you may well get symptom remission at 70%, but good quality of life, functional remission, these are complicated pictures to look at. It's not straightforward. And it may well be just that group in there, a third, that get complete recovery. Now, outcome early intervention, the Danish Opus trials and my colleagues in the centre of London, Maudsley Hospital, done quite a lot of work to show early intervention services work really well. And if you stop them after 3 to 5 years, the outcome's not so good. But then some psychoses are lifelong. So stopping the service is bound to be, in my view, obviously associated with a detriment to the patient's care. So what I'm suggesting is that actually, and there's now, I think Belinda Lennox, who's new head of psychiatry, head of department in Oxford, is looking at extending the early intervention psychosis provision. But that just makes sense, and it would make sense in Turkey as it makes sense in the UK. And the last paper here, I think it's, I'm sorry, I cut that off, Belinda Lennox would be there as well, is the early autoimmune psychosis. If you get a patient come in with altered neurology, altered sense of consciousness and things like that, sudden onset, it's very, very important to do the screening, correct screening. If it comes back negative, check that you're doing the right autoimmune antibody tests. If they're static, they're probably worthless. You need to do the live ones. So go to your researchers, get the blood sent to Istanbul to get the labs, look at them properly, and get a neurologist's opinion, because it may well be that actually you'd want to treat with this. The treatment's completely different. It's immunosuppression, and for the very severely unwell, it'd be important to think about immunotransfer. In other words, you actually take all the plasma out of the patient and remove the antibodies that way. Straightforward treatment you use in neurology for autoimmune type diseases, and you get tremendous response. They're very few and far between. I had a patient who later was discovered to have an autoimmune encephalitis, but when we had him, he was acutely psychotic, terribly ill. We actually treated him with ECT. No, later we treated him with ECT, but he was much better. But actually, as I noticed, his eyes were just blinking just a little bit too much before his mother took him into town for a first outing. He comes back completely psychotic, and it was only settled with ECT. Years later, he was referred to Belinda Lennox and was found to have high rates of autoimmune antibodies here, brain antibodies. But he declined treatment, or his consultant psychiatrist declined treatment in the Southwest, and he killed himself. So it's a sad story. Because we're at a conference, we always want to have something new, and I think watch out, lamatopirone, which I haven't used yet here, but look at this here. We've been talking about dopamine, but we realize that it's not all dopamine. It has to be considered where there's glutamate here, second generation, that has higher affinity for serotonergic receptors, dopamine, histaminic, pre-synaptic dopamine partial agonist, serotonin reuptake inhibitor, and an indirect modulator of glutamatergic systems. So those are the kind of drugs that we may well be needing to look towards. And I'm just wondering who's going to do the first trial of that in young people. If you're interested, let me know. Okay, I think that's about it. That just says. Okay, thanks.
Thank you.
We have time.
Thank you, Professor James, for this excellent speech. If you any question, we can get.
Are there any questions?
Yes.
Yeah. I did ask you for questions, didn't I? So
Yes, microphone. Yes.
I might need to come down because I still can't hear miles away. If that's all right with everyone.
Dr. Tonya White will ask a question. Okay.
Thank you very much for an interesting presentation. I had a question about, you showed some of what Jim Van Os presented in his thoughts of psychotic disorders across a continuum. And I was wondering about this. So with schizophrenia, sometimes we see those with primarily positive symptoms, so the psychotic symptoms, but not many negative symptoms. They respond well to antipsychotic treatments, and Nancy Andreasen used to call those individuals, they would pass the bus test. That means they could travel on a bus, you would never know that they
Yeah.
had schizophrenia, and they show
Yeah.
really nice recovery. Then there's those with the negative symptoms, and you were showing that that's really problematic to treat, the negative symptoms of schizophrenia. So do you think it's the negative symptoms that also have a continuum or just the positive symptoms? Or are they, how do you envision those two as separate, independent, or together?
It's a very interesting question because who the hell knows? Because the contention would be the negative symptoms would just slip down. They might just drop out of society. They certainly drop out of school. If you ask teachers, do you know anything about this person? He's now in a unit. They say, I don't know. He was doing quite well, passed his GCSE, passed his common entrance to get in public school, and they would just chuck him out to school because he's failing in his exams, or they say he's smoking weed or something like that, which he might well do. And I suspect if you look at these people might well just, part of the continuum will just not do very well. They become homeless and difficult, unemployed and things like this. So no one's going to do a survey on them. No one's going to really understand what's happening to them. Your study might well be able to answer that in terms of being able to pick them up. But I think you're quite right. The distinction anyone can treat positive symptoms is dead simple, really. But negative symptoms, I think Chris Hollis did a lot of work on childhood onset schizophrenia from the Maudsley and was now moved to Nottingham, suggesting that's probably the core of schizophrenia is the negative symptoms. And what Jim Van Os is talking about is a different kettle of fish. Now, to be fair to Jim, he's not saying there isn't schizophrenia. He's made his life. But he's saying that actually all the energy has been put upon treating that group and to the neglect of those who have psychotic experiences, which are more readily tractable. And actually, I suppose it would be worth wondering, there is a treatment for the negative symptoms, which would be some antidepressants, but I don't have an awful lot of details on that. But I think if you looked at the name will come to me, the Maudsley group down there trying that with trials. I've forgotten his name purposefully, I think. but anyway, but antidepressants are in the armamentarium for treating negative symptoms, and there's some positive indications for that. Sorry.
If I could ask just one other question, kind of tying into that, and also a kind of a relevant question for this day still in the midst of this COVID pandemic, and I heard that the Netherlands may be going into a full lockdown coming up, and you have a group of individuals who have some level of paranoia. Do you think that's playing into this? What do you see the role of the people who choose not to be vaccinated and thoughts of paranoia? If you did a study on that, what would you expect to find?
I haven't a clue. I just don't know. What I do know is that actually, I don't know whether it's in Turkey, but certainly in the UK, incidence of untreated eating disorders has just rocketed. The ward is now full with that. And I think it shows the value of actually intervention, because our eating disorder colleagues just didn't see the patient. You need to make face-to-face contact, and they deteriorated. And some young girl we saw was given a diet sheet, just met with a dietitian. Next thing, she was admitted from intensive care physical because she'd lost so much weight. So it's more upon those, and we have not seen a spike in those patients with psychosis. In the last 2 years, I think I've had 1 or 2 patients with psychosis on the ward. One of whom was a boy who had treatment-resistant schizophrenia, and I spoke to him, and I said, I spoke to the consultant who was going to treat him afterwards, and he said, I don't want you to put him on clozapine. I said, well, he's assaulting staff, he's not responded, he's completely crazy. I think he needs to be on clozapine. He said, I don't want you to put him on clozapine because I've had, and this is bad science, I've had 2 patients, young men on clozapine who've had heart failure. And I don't want to have a third. And I'm saying, look, I'm sorry you've had 2 patients with heart failure. That's just your pick of the bunch. because the evidence is, yes, it does cause this, but actually you can't. You've just had bad luck. That's all there is to it. He said, no. So the patient went all the way to the Morse to be clozapine and actually came back. But the point I'm making, rather belabored story, is that we just don't see young people, males in adolescent services with psychosis any longer because we've got community services, which is a plus. Amazing. And we have not seen a spike during COVID, which is not what you thought.
Okay, thank you.
Maybe they're all taking cannabis or something to calm themselves down. Any other questions? Please don't be shy, because your last chance, you're going home soon. It's all clear, is it? I didn't actually produce this talk to make it clear. I actually wanted you to be confused. If you're not confused, then it's obviously failed.
You said firstly negative symptoms is important in the schizophrenia.
Sorry?
Negative symptoms
Yeah.
is more important than positive symptoms in understanding of schizophrenia. I understand.
Yeah.
What do you think about a child come to us with only negative symptoms, but we know that not all of them go to schizophrenia or like this disorder. Some of them maybe relief. And another question is, what do you think about the omega-3 or 6 fatty acids like this? Some patients, some doctors refer to use them.
Well, it's a very interesting question because some of the most difficult differentiation of symptoms are those between who has negative symptoms, withdrawn, apathy, total isolation, and who may have some autistic traits beforehand. So the possibility, the differentiation between that diagnosis and a diagnosis of autism is extremely difficult to make. And I think our predecessors would call that, I can't remember what it was, but there was a kind of like a schizophrenia, but it wasn't kind of schizophrenia, if you remember. It's on DSM-4 and DSM-3, a kind of negative state that didn't have positive symptoms, but is called latent schizophrenia. That's been abolished. People said that if you don't make the diagnostic criteria, you haven't got schizophrenia. What they're saying is if you haven't got the positive symptoms, you don't make the but there's still something very seriously gone wrong with this person, exactly as you say. And I think, to be honest, if you in a hospital setting and things like this, I think a trial of medication may well be certainly suitable. But what would you give? Clozapine might well be important. Antidepressants might be important, but I think the important thing there would be to get an opinion from someone else, review the literature, and actually saying, all right, so they've got some autistic traits, this, that, and the other, and the important thing is, having spoken to those in neuropsychiatry, is there's been a decline in function. Now, there's often a decline in function in adolescents for those with autism, yes, because of social demands in that. But if it's more than that, and you've got an expert who's saying, this is more than I would have predicted from the autistic picture, then I would treat it, if you can. Then the question becomes, as I'm sure in Turkey as it is here, if the patient's not competent or got capacity, can you do it without legislation? That's an interesting one. I would have a go. I think we're not aggressive enough. That's my view. Provided you're safe and take peer review and things that some people are willing to defend your actions in court, I think you should be much, much, much more aggressive than we are. That's my view. You don't have to take it. You just heard it here, that's all. Blame me. I'm not coming to defend you in court. No, that's for sure. Anything else? Yeah. I will come up because I can't hear so well. I'm sorry. Well, if you...
Oh, you should...
Well, okay, now it's working.
Okay.
I want to ask a question. You showed a graph of brain scannings and you compared a schizophrenia patient and the sibling.
Yes.
And you said after 14 age something changes. I couldn't understand. Can you please explain that?
Oh, that's the whole point. No one knows.
Oh.
No one knows. So that's down to you to find out.
Okay.
It's in the paper. Have a look. But I mean, Judith Rappaport, she presented the data to, I spoke to her about this particular paper, and it's interesting that the difference between the siblings and the patients who actually have it is this maturation does seem to change at 14. It's undoubtedly genetic, but if you want, you need to be able to look at those differences between the two. Now, she may have moved that work forward. Judith Rappaport was retired, but Gogte hasn't, so you have a. She's very good at replying to emails. I sent an email to her, and she said, a reply came 72 hours later, and she said, I'm sorry for taking so long to reply. So she will reply to your email.
Okay, thank you.
What about the omega fatty acid addition to the treatment?
She asked omega fatty acids. Okay.
Moderator.
I'm just not aware of trials of that in childhood and adolescent onset schizophrenia. I might well be wrong, but I think there was quite a lot of excitement for this earlier on, and I think there is some evidence, but not strong evidence. Certainly the NICE guidelines, National Institute of Clinical Excellence, don't highlight that as an effective treatment. What they do in adult schizophrenia, which may be helpful for you, is art therapy. Art therapy is endorsed by National Institute of Clinical Excellence for treatment of adult schizophrenia, and it's a participatory activity. So, just a thought. Sorry, I'm turning my back on you all the time, but there we are. Right. Well, I think it's a sunny day outside, and it's Saturday, so if there isn't any further questions, I'll go and see if my football team are doing quite well. Okay, thank you.
Okay, thank you very much. I think there is no other question.
Yeah. Thanks for your very brief and